I'm JC. I'm one of the co-founders of BIC, and I wanted to quickly go over the benzodiazepine tapering draft guidance from the American Society of Addiction Medicine. We have a few videos from Nicole Lamberson explaining quite a bit, so I'm just going to actually try to make you feel a little bit less intimidated about the content. So if you go over to asam.org and you click on the top, you'll see guidelines. Then you click here, it's referring to the new benzo guidelines. So you click here, and there's 3 parts. Everyone has to do a disclosure form. So just start here with the disclosure form and go straight over. It's not going to show me because I've already done it. It's very easy though. And you can use a fake name, you can use whatever you want in the disclosure form. But if you use a fake name, use the fake name when you provide comments, which I'm going to open over there. And let's just go over to the draft guidance because I'm not going to do too much of the comments. Like, you just put a fake name, you would put patient, you would put no unless you're submitting it for an organization, and then you click next and it would start asking you for the page number and line number of your comments. So let's just go over here. It's intimidating looking. It's a very busy PDF, which isn't the great for benzo brains. I have one too, but let's just go ahead and skip. So this isn't as important for you. The background isn't that important, although you might want to comment on something in here like people who have been taking benzos for longer than a month should not abruptly discontinue. I think most of us would agree with that, and maybe even make it shorter. But they do say maybe some people under 4 weeks might have a taper. So then we get into the key takeaways, and this is the things that they want people to understand when reading this guidance. I have to note, we don't agree with a lot of these, but we do agree with some of them. Number 1, in total agreement, approaches should be in collaboration with the patient, utilizing shared decision-making strategies. I think most of us would greatly appreciate if our doctors were interested in shared decision-making with us as we attempted to taper off of this medication. So then we get into clinical recommendations. And this is like when the use outweighs the risk, which makes sense. Tapering is generally indicated. I think that might be a little strong because just because someone is physically dependent and they're using it and they are no longer benefiting from it does not mean they're going to be able to come off of it without actually getting worse. And you're going to see throughout this document, if you look at it, that the protracted issue is completely ignored, and that needs to change. So if you're going to leave one comment, and only one comment ever, just put line 0, page 0. You need to talk about protracted harm and send it. That's it. That's the only one you got to leave. If that's it, if you can only do one, do that one. Choose the disclosure, move on with your life. Because all of this is due like next Friday, I think, which would be July 19th. So let's go back to this. Okay, so back here, we're going to look at what they're concerned about. And this one really stands out to me. Clinicians should taper benzodiazepine in most older adults unless there are compelling reasons for continuation. Again, it's not a good idea to force anybody off of benzodiazepine, and it can actually be very damaging and deadly. So that's the compelling reason right there. But since this whole document is ignoring protracted harm, I think they need to be told that older adults should be left alone. We get emails all the time. They're so heartbreaking from older adults who have been forced off simply because of their age, and now they're disabled. So they get to spend years and years of their lives trying to recover from that. It's terrible. That one, if you have a second one, if you have a second time for a second comment, page 5, line 21, older adults should not be forced off of benzodiazepines simply because they are older adults. Everybody should be able to make that decision for themselves. I understand they process benzos a little differently, and that's what they're trying to avoid. But in my opinion, first most prescribed group is the age group right behind the older adults. And that's how you reduce harm, is you stop prescribing it to the people right before, or at least new prescriptions. I think everybody who's already on should be grandfathered in and left alone unless they want to try to come off. Anyway, so let's move on. They have harm reduction strategies. This is related to opioids, which doesn't have a lot to do with most prescribed patients. Benzodiazepines should not be abruptly discontinued in patients who have been taking these medications daily or near daily for longer than 1 month. That's pretty good. I would say to go back even longer and just ask, is physical dependence present or not? Because if it is, then they need to taper, and if it isn't, then they might not. But physical dependence, and even the FDA admitted this in their own boxed warning Freedom of Information Act that we've received, physical dependence was developing in some people in like a day or two. And those people would need to taper, where there's people who, do not have physical dependence and they've been on it for a month or longer. It's a very individual thing, and I think this should reflect it, but I agree with the spirit of it. So number 5 says, this one's dangerous. While most patients are able to complete benzodiazepine tapering in outpatient settings, inpatient or medically managed residential care should be considered when the patient's presentation indicates significant risk that cannot be managed in an outpatient setting. Okay, this one's very vague, and maybe they elaborate later because this document is pretty long. But this is going to get people sent to detox who should not be sent to detox. I think there's 2 points that really needs to be made here. One is that inpatient care, medically managed residential care, does not have good outcomes for benzodiazepine tapering. So if someone's already struggling, the last place you would want to send them is somewhere where it's going to make them struggle more. I think there's exceptions to this. If someone has a true paradoxical reaction, maybe this is the best indicator, but this is too vague. It's not appropriate. Or maybe someone with a substance use issue who is going to end up dying from something, but most patients are prescribed patients, they're compliant patients, they're not misusing the medication, they're not abusing it, they're not addicted to it. Okay, so that one's important. I would comment on that one. Number 6, the tapering process should be designed to minimize withdrawal symptoms while balancing the risk of continued benzodiazepine use. They seem to forget who gave you the benzodiazepine in the first place. This was supposed to be a medical thing that helped you. But anyway, that's besides the point. The initial pace of benzodiazepine should generally include dose reductions of 5 to 25% every 2 to 4 weeks and no more than 25% every 2 weeks. I agree with the 5, but the 25 is too high. And I would like everyone to comment on that, which would be line 1 of page 6. 25% is too high. It should be 5 to 10% or less every 2 to 4 weeks. And people can go faster if they're not having trouble with that. But we do not want to harm the patients that are the most vulnerable in the first reduction, because I worry that doctors are going to read that and go with 25% instead of 5%, because it's harder to get a benzodiazepine to 5%, like to manipulate the actual drug to 5% than it is to 25%. And since it doesn't talk about protracted in the whole document, they're not going to understand the stakes of doing this. So that would be my suggestion. Okay. Tapering strategies should be tailored to the individual patient. We like this. And adjusted based on patient response. Yes, this is good. They should be monitored for emergence of benzodiazepine withdrawal symptoms with each dose reduction. The taper should be adjusted if significant symptoms emerge. I'm in total agreement with this. I'm on the patient panel for ASAM, and this is something we stressed with them a lot. This and their first point, that it needs to be collaborative and it needs to be tailored to the individual patient. And I'm glad that they've adopted some of this. All right, number 8, patients undergoing a benzodiazepine taper should be offered psychosocial interventions. See, let me tell you a story about this one. They put this in there because they couldn't find anything. They went through all the literature and they couldn't find anything that consistently helped with benzo withdrawal. And they say somewhere in the document not to use certain medications that are very commonly used, like gabapentin, which I think is a win. But they had to put something, I guess, like sleep. They just have to feel like they're doing something, I think. Like, there's no evidence that CBT, maybe there's a little, there's not, most of us who have been through this, it's not a thinking problem. Like, CBT is supposed to address cognitive distortions. Benzodiazepine harm is not a cognitive distortion. And sleep hygiene education feels like kind of an insulting joke when you can't sleep because you're in benzo withdrawal and your body is a mess. I think it's just going to frustrate whoever does sleep hygiene education and therapists, because they may not be prepared for this either. So I think they should take that whole one out. But I think it would make sense to have things like assistance with shopping or stuff like that. Like some people could really use in-house assistance, like because they're so disabled. But again, I don't think the people writing this understand how disabled we get. Okay, number 9, patients undergoing benzodiazepine withdrawal management in an inpatient should be monitored for signs and symptoms of withdrawal. Like this is like a duh. Seizure risk. First of all, most people should not be inpatient, but if they are, yes, you should monitor them for seizures. Thank you. I appreciate that. Okay, so number 10, concurrent treatment should be provided for any co-occurring substance use or psychiatric disorders. That's tricky because how many of us have been misdiagnosed as having psychiatric disorders for having benzo withdrawal? I don't feel like the medical field is in any place to identify relapse versus withdrawal symptoms, so I kind of don't like that one, but I also feel like they have to put it there. You're going to see that all of this guidance is really not specific. It's not going to be like, okay, taper this. Like, I don't know if anyone's seen the Maudsley Deprescribing Guidelines. You should not only look at it, you should own it and buy a copy for your friend. Mark Horowitz is a genius, but it's nothing like that. So I would personally refer anyone to Maudsley if they wanted to seriously learn how to taper and show their doctor how to taper. All I'm trying to do here is to make this as good as it can be and the least harmful it can be. Really, if you want to comment effectively, you could even just look at the first, I believe it's like the 10, 13 pages that we're going to be going through and comment on those, and you would probably do a decent enough job. Okay, so for each patient taking a benzodiazepine, they should ideally assess the risk and benefits of ongoing prescription at least every 3 months. Oh, another thing you're going to notice is these keep saying clinical consensus, and all that really means is the people on the board agree. It doesn't mean there's a lot of evidence for it and how strongly they recommend it. So a lot of these are going to, I think all of them are going to say clinical consensus, strong recommendation. But again, let's go back and discuss when they were first putting together this group of people. I believe a lot of people from the Alliance for Benzodiazepine Best Practice, another nonprofit, and our organization, Benzodiazepine Information Coalition, including the late Dr. Christy Huff, applied to be on this medical panel, and all of them were rejected. So a clinical consensus from one group will look very different from another. And I don't believe ours would be the same as theirs. I mean, every 3 months, I don't understand the value of that, really. Because then what? Like, are you going to force them off if you decide it's not going well? I just in general think doctors don't understand benzodiazepines enough to even prescribe them if we're being real, but at least long term, because, okay, they could be intolerant. Maybe you increase the dose and it would improve. It's too vague. So they want to do the risk and benefits. Can you imagine like being on benzos for 10 years and then you go in 10 years later and for a refill and you get this whole spiel about the stuff you should have been told 10 years ago? So I agree that prescribing clinicians should read the prescribing literature. Tapering is indicated. I think that, again, if someone is physically dependent and they were made physically dependent through their prescriber without any warning, they should not be forced to come off if they don't want to. And if they do want to, it should be on their own terms. Alternatives managed. I mean, see, alternatives for the underlying condition, that's kind of skipping the whole becoming disabled from the cessation process, isn't it? Again, you can see the people creating this document don't really understand that part, and that's probably the most important part to understand. That being said, clinicians should absolutely avoid abruptly discontinuing benzodiazepines in patients who have been taking them daily or near daily for longer than 1 month. I would say if physical dependence has occurred, it doesn't really matter how long, they should not be abruptly discontinued. So, okay. If significant symptoms emerge, a clinician can consider medications for symptom management, restarting the benzodiazepine, or like what medications for symptom management. I know that they didn't find any in their review that consistently worked for symptom management, so I don't understand why it's here. But again, it says clinical consensus. This is not going by the review, and it's conditional. It's not a strong recommendation. I think if you wanted to comment on this, you could say page 7, line 13, and say that there aren't any medications for symptom management and be accurate. Even better if you can find a citation for that. Okay. Level of care considerations. Inpatient should be considered. This is one where we freaked out. So the patient presentation, like suicidal, self-harm, is at imminent risk for significant self-harm or significant harm related to continued benzodiazepine use. I don't think cold turkeying a suicidal patient is going to make them less suicidal. It's just not. That's ridiculous. Patient symptoms or co-occurring physical or mental health conditions cannot be managed safely in the outpatient setting. Seizure disorder. I don't know anything about seizures, so I'm not going to say anything about that. The patient is experiencing or imminently anticipated to experience severe or what does that mean? You're going to experience severe or complicated withdrawal. The patient has a history of severe or complicated withdrawal. Okay, this is where they're talking about us, and they're basically saying to send us to detox because we're complicated, and that doesn't make any sense. And again, if you're going to speak out, page 7, line 25, this does not make any sense. I feel like almost when I was reading this the first time, I know it sounds like I'm just reading it the first time, but I promise I'm not. I just don't have a good memory. The first time I read this, it was like they're sending people to fantasy detox. Like, this doesn't exist. There's not an inpatient facility to manage complicated withdrawal. We would have all went if there was. So there's no value in this to me. And again, it's clinical consensus. It's not from evidence. It's a strong recommendation. And it doesn't make any sense if you have a history of severe or complicated withdrawal. You should be sent to inpatient care. And I don't even know if they're talking about like a psych facility or detox, but I know that there is no facility to send us to. I think all this does is get you out of that prescriber's lap and out of their problems and passes the buck somewhere else to your detriment, because then if you get harmed or die from there, they're not going to track outcomes, and they're going to keep this recommendation no matter what. It's very dangerous. So again, this is one that I would highlight. If I had like the top 10 to highlight, this is pretty high up there. Okay, recommendation statement for partnering with patients. The benzodiazepine tapering strategy should be developed in coordination with the patient and their care partners and in a shared decision-making process whenever possible. Yeah, I agree with that. That's pro-patient. And what would this look like? Bringing the Maudsley in or the Ashton manual in and saying, this is how I want to taper. And the doctor, being like, okay, let me read about it. And, working together on that. Like, that's a good thing. Okay, tapering process recommendation statements. Prior to beginning a taper, clinicians should conduct a thorough medication and health review with particular attention to other psychoactive medications and conditions that may be impacted during the taper. This sounds good, but I don't know if the knowledge base in medicine is high enough to really perform that, but whatever. Here they go with the 25% again. If it said 5 to 10%, I would be very happy. If we could do page 8, line 9, and say 5 to 25%. I did look for evidence of this, and what I ended up finding was a lot of people dropping out of studies who did do 25%, but then they didn't follow up. They didn't ask why did this person drop out of this study. It's just like, oh, well, half of the population dropped out. I wonder why. Where it's like, because you were tapering them too fast. That's why. Clinicians should consider current benzodiazepine dose and half-life, frequency, and duration. See, they're not going to talk about things like interdose withdrawal. I don't think. They do talk later about switching over to Valium for some, but the conversion chart is at the very end, so it's not clear enough. Again, Maudsley deprescribing is so much better, but I would at least like this document because we're going to be stuck with it for a while. They're going to get as many medical boards as they can to sign on to it, and the FDA is paying to develop this with ASAM. So we're going to be stuck with this for a while. So if we can leave comments to make it better, we should. I think they sincerely do want to make it better, but they also want to go by the evidence, and maybe they're a little leery of how damaged we're saying people are, which is why if they heard it from you, it might be better. If they heard it from 20 more than they've heard it from, it might be better. So please at least leave one comment. Okay, so the overall tapering strategy should be designed to minimize harms, considering the risk for withdrawal symptoms and the risk of harm continuing to benzodiazepine use. I would say for most people, the withdrawal symptoms are riskier than the harms of continued use, but not everybody. So I just don't understand how physicians who haven't been trained about this at all can assess this. It's kind of unrealistic. Sounds good on paper, doesn't really, I mean, most of us have seen pretty clueless providers at some point and can say like, oh wow, they would never be able to actually perform this. But let's move on. So this is where they're talking about a longer acting benzodiazepine for the taper. It would be helpful if they said exactly how, because you can't, a lot of doctors think you can just switch, and you can't. You're supposed to do a stepwise slow crossover at an equivalent dose, and it's actually very tricky to find the equivalent dose. The ASAM manual equivalence chart is higher than others, and some people that works, it's going to be very individual. So tapering should be tailored to the individual patient and adjusted based on the patient response. Agree with completely. I just don't know if the skill is present from reading this, or currently I don't think it is in providers. Patients undergoing tapering should be evaluated for signs and symptoms. Yeah, that's fine. But what are you going to do if they are? Send them to detox? That's where it becomes like unfine. For patients experiencing, I know they took this from us, for patients experiencing significant symptoms related to benzodiazepine taper, clinicians should consider pausing or slowing the pace of the taper or making smaller dose reductions. Okay, so that came from us, and that we absolutely agree with, over sending people to detox because they're having trouble tapering. All right, number 10, the benzodiazepine tapering process can be more difficult for patients as the total daily dose of benzodiazepine decreases. Yes, that's hyperbolic tapering. That's in Maudsley Deprescribing too. They should proactively consider smaller dose reductions or slowing the pace of reductions as the taper progresses. That is correct. That is good and wise. All right, if a patient is unable to tolerate further benzodiazepine dose reductions, the clinicians can consider maintaining the patient on the lower dose with regular risk-benefit assessment consistent with recommendation 1. I have a couple questions here. What about when they reach tolerance? Why not just reinstate them to the other dose? Are they going to be up-dosed? Or if they can't go further, you're going to make them go further later. But I totally agree with not forcing people off. Like, I'm very, very pro that, and most of us at BIC are, if not all of us. Okay, so here's some add-on recommendations. Psychosocial intervention should be offered. Patients, CBT, sleep hygiene, physical activity, complementary health approaches such as mindfulness practices, peer specialists, that would be kind of like benzo buddies or a coach or something. There's actually a peer specialist program that we participated in out of Colorado. So I agree with this, but I also think people need help with their home. They need help with laundry. They need help with cooking, like even like nursing. Some people do, not everybody, but some do. For patients experiencing symptoms that significantly interfere with the taper, clinicians should first consider pausing or slowing the pace of the taper. And then they mentioned medications. So I have to respect that they said slowing the taper first. The medications, it's like, which ones? If, as all of us know, not ever proven to work consistently. There's just a lot missing here. Okay, so patients undergoing benzodiazepine withdrawal management in an inpatient or other medically managed setting should be monitored for signs and symptoms of benzo withdrawal, yes, and seizure risk, yes, they should, but most people should not be there. Tapering with very long-acting agents should be typically conducted in an inpatient or medically managed setting. This is like phenobarbital. Sometimes in inpatient, they switch people over to pheno and taper that. And the reason they do that, I learned from Dr. Raymond Armstrong, who used to serve on our medical advisory board before he passed. And he said that back in the day, they had no idea what to do in how to get people off of benzos. Back in the day, I still don't think they do, but they would send alcoholics to detox. So they thought, well, we should send benzodiazepine people to detox. And then before benzos, they used to give people phenobarbital when they detox them off of alcohol. So then they thought, well, maybe we should give people phenobarbital to detox off of benzos. And that's really all it came from. Not much more than that alcohol and benzos are similar to the brain, so they should use phenobarbital. Following a taper, discharge planning should include outpatient follow-up, ideally within 7 days. physiological taper. I don't know what that means, so I'm going to skip that. The follow-up, the clinician should assess the patient for ongoing symptoms related to benzodiazepines. I think this is just all inpatient stuff. It seems like they're warning nothing about the biggest risk of inpatient, besides like just seizures and dying, is protracted harm, suicidality, being forced back on the drug. Like, so they said avoid general anesthetics. All right, so people who are co-prescribed benzos and opioids. I mean, this stuff doesn't really apply to the most of the people who are going to be commenting, so I'm just going to skip that one. People with benzodiazepine use disorder or co-occurring, oh my gosh, I can't talk, co-occurring substance use disorders. Most of the people in our community are not experiencing this, so I'm going to skip this one too, but you can read it. Co-occurring psychiatric disorders, that happens in our community. I don't know what locus is. Use existing standards for level of care recommendations. I don't know. Clinicians should consider optimizing evidence-based treatments. Again, this isn't really saying much, is it? Patients with PTSD. Clinicians should strongly consider tapering benzodiazepine medications. I mean, I know that they don't work well for PTSD, but that doesn't mean forcing people off is going to make their life better, especially if they experience severe withdrawal and become disabled from it. I think it should be very much an individual decision. I agree that they should monitor sleep, especially for people who become manic or experience psychosis. Absolutely. This one bothers me a lot. It's page 12, line 24. Clinicians should taper benzodiazepines in most older adults. Again, they need to give honest information so that they can receive consent from the older adult to basically potentially have their life upended for the foreseeable future. I just disagree with that one completely. I want that one gone, if we're being real. Like, they need to change that one. I understand they should avoid prescribing benzos to older adults in the first place, but the ones who they did not succeed in doing that should not be punished due to that. That being said, some older adults, when they come off of them, do experience improvement. So it's not like it should never happen, but it should definitely be made with a realistic understanding of the worst case scenario, because the worst case scenario is bad. And we're going to talk about pregnant patients. The problem is it's very hard to get off of benzodiazepine in the time it takes for a pregnancy. Psychiatric symptoms during the taper that may require treatment. Okay. Clinicians can... Oh, you can refer, get it out of your hair. With expertise in reproductive psychiatry, those people are still not going to know how to taper a benzo. Encourage breastfeeding, which can reduce neonatal withdrawal symptoms. I thought it did pass through breast milk. Communicate with the infant's health provider regarding exposure to benzodiazepine. Like, that's fair. That's probably what's going to end up happening. Okay, so that's the first 13 pages. You could do your whole comments just based on that, and you could skip any of these that don't apply to you. So, I mean, it took me a while to go through these, and I wasn't really elaborate, but I just wanted to get something up to hopefully make it a little bit less intimidating. But if it is more intimidating, go ahead and leave your comment, and I'll try to get to it. It's really important that you guys participate, because if not, all this harm doesn't exist if nobody tells them it exists. I mean, we're telling them it exists, but they need to hear it from someone other than us. So I really hope you do speak up. Again, it has to be done by the 19th. Unless there's a new thing, unless you need an accommodation because you can't read this, like if you have dyslexia or you're having trouble reading it, they have a version they're developing that doesn't have all the numbers on the side that can actually be put through a machine, if you have one, that reads PDFs to you. And you can get an extension if you're in that situation to the 26th, but you have to email. It's not going to be on their site. Nicole made a video recently on where to email. It should be our previous video if you want to go watch that. But again, we really need your help. Please don't let this go. After the 19th, it closes and you're never going to be able to comment again. The activists in 2017 who reported everything to MedWatch, there was like 6,000 to 9,000 who did it. And right now we only have like 50. So Where is everybody? Like, this is really important. It wasn't easy to do the MedWatch reports either, and we did have more time to do them, but we do need to get these done. It's go time. At this time next week, I'm recording this on Saturday, it's going to be closed, and that's it. We don't get to say anything ever again as a community about this. So I hope you guys participate. Thank you.